and we need to redirect where the fuel is going. Private care enhances elective, easy procedures. Philosophical change to elder care is paramount to beneficial change in the acute care of seniors. If there's one thing that I can bring home this morning, is if we can promulgate in every one of our environments a positive attitude to seniors and their care, we will go a long way to solving the crisis in the future. I believe we can reorganize current acute care services and greatly improve our care of seniors with little, if any, cost increase to the system. Thank you. This question in the back, yes?
Actually, Roger, I hope you don't mind, but it's a clarification. The ALC strategy, as you know, that we're working on it and looking at and changing it. It actually wasn't shelved, it was part of our planning.
Great to hear that. Great to hear that, because I've been going the other route now. Sometime next couple of weeks, and I'm going to try to go to every one of the places in the hospital that I had those little red points, so that I can start asking the staff to see if this fits, if this, for you people in the audience, if this makes sense or not. That's what I like to have feedback, because I've talked to a number of people about this, and these are observations I've made through my career, and I haven't walked through hospitals and see how these complex factories work. But I think if we were to follow a model like this, we could make our system work a lot better. Anne, good question.
What I enjoyed about your presentation is that we already have all the resources, and all we have to do is carve out and redeploy existing services to achieve this goal. And the part that I wonder about is, well, it's happening everywhere else in Canada, and why are we so slow on the uptake here? Because we're one of the few places in Canada where home care services haven't been reconfigured. What's the reason, do you think?
I think lack of allied health resources, appropriately trained allied health people in the community. I think we have to push back from a philosophy of constantly thinking about the fire that we're dealing with in acute care, because people in acute care are working that factory to the best of their ability to sort it out. But the problem is their outputs that I show on this, the green outputs, are clogged up. Our nursing homes are clogged up. Our personal care homes are clogged up. We don't have alternate housing in the community to deal with a lot of the problems that arise. And if there's one thing that we could do tomorrow is I'd like to hire, if you look at the report that went in for the rehab program, there was 199 allied health workers that are needed on the ground now to meet the needs of Eastern Health District alone. If we are trying to bring up our level of care to what's expected across this country today, we have a deficit in our community of about 100, I think it's 199, maybe I'm wrong on that, Larry, you can quote me on that. I think it's 197 allied health workers. Can you just imagine, remember what I just showed you in that slide with Dr. Kaplan? We're looking after those 35 acutely ill people. He has 14 nurses, 2 OTs, 2 physios. Now, people need to understand that there's only a very small proportion of seniors who are sick, and these are medically frail. So this is about 15% of people that at any one time are going to be falling off the wagon that need support. This is not a huge number, because if you take 100 elderly people, they probably don't consume any more healthcare resources than younger people do. But if you look at it, if you focus on the frail elderly, which is I think we need to put our focus, we can radically improve their care. We can improve the congestion in our acute care hospitals, but it has to be a systematic approach. So just talking about the acute care hospital ain't going to do it. We have to have a blended plan that goes from the home, and I think the home is where we got to put the focus. We got to use all our means and all our creativity to keep people in their homes with the supports they need as long as possible.
There's another comment or question here. Yes.
Roger, I can't agree with you more. From 1990 to 1997, I was doing 200 house calls a month, and a lot of preemptive, doing IVs, and had a nurse to help me, a physiotherapist to help me. Biggest thing that I found was changing the mindset of people, accepting what you're doing.
Right.
And if you do it piecemeal, it doesn't work. You have to have it all together. I ran into problems with MCP, ran into problems with board. So it works, and it works very, very effectively. And when I went out of practice in 1998, I had 60 people die within the first 3 months.
Yeah.
So these would have been people who had been into the system, clogging up pathways.
Yeah. How sick people you can look after in their homes. Pat and myself, all the people who are doing house calls will tell you that the intensity of sickness in our population that we're seeing on house calls is like quadrupled in the last 10 years. And it's going to quadruple again in the next 10 years because that 85 age group are going exponentially. I couldn't, I just think we need to somehow, what they did in Australia, which works, is that the funding goes with the patient. And they have a very well-developed screening tool. And what I really liked about it, I went to one of their screening meetings, and they have a triumvirate. So of us 30 people in the room, we're probably experts in the field, we would vote on who would be a good person to screen elderly people. Because they know that when you're screening for elderly people for placement, that's high dollar utilization. So you want to have the best people who can do the screening involved, and you want to have the best care for the patient, right? That's what we're about. So they take the experts who know. And you don't get paid for that, but it's like an add-on to your day. So you're going to take this thing for half a day a week, and you've got to sit down. And I had this patient that was presented at this case with a stroke. And the social worker came in, and she presented this case, said, well, I want this person now to receive additional support so that they can be placed in a nursing home. They're in acute care at the moment. They've been there for a week. They've had their stroke. And I talked to the neurologist. The neurologist said there's no hope of recovery, and the patient should be replaced. And there was a doctor, a nurse, and I think it was a social worker on the committee. And they looked at it and they said, do you mean to tell me this patient didn't have rehab? And he said, yes, but the doctor said he didn't need rehab. He said, that's not appropriate. 1 week is not appropriate. This patient has to have rehab. Come back in 6 months after the rehab has been done, and we'll talk to you again. In other words, they are very strong advocates that seniors get the care that they need when they need it. The pressures in the system often make us as doctors in acute care, make decisions that may be appropriate for the time based on the pressure on the bed, but not appropriate for the patient in the long run.